Hello, everyone, and welcome to the third and final session of Returning to Primary Care, Diabetes Care During a Public Health Crisis. My name is Luke Ertl, and I'm the Program Manager with the Quality Center within the Clinical Affairs Division at NACC. And I'm joined today by Cheryl Modica, Director of the Quality Center, Camila Silva, Specialist of Health Science Content, and Rita Lewis, Deputy Director of Clinical Quality Improvement. We're also joined today by Aaron Frazier from Harrisonburg Community Health Center. I would like to review a few housekeeping items as we get started. We'll be holding a Q&A session at the end of this webinar, so please send us your questions at any point throughout the webinar via the chat box. You can also raise your hand during the Q&A portion of the webinar if you would like us to unmute your line to ask questions or comments. With that, let's go ahead and get started. I'll now turn things over to Cheryl Modica.
Great, thank you, Luke. And if we could advance to today's objectives. Again, welcome to the third of our three-part diabetes series. So over the course of the hour together, we're going to walk through three large content areas, as well as have time for discussion and, as Luke described, chat and the opportunity to communicate amongst one another and share resources. But the three parts of our conversation today will be first, continuing sharing of NACC's diabetes change package, and Luke will call out several of the evidence-based interventions that are included in that diabetes change package, as well as direct you to some resources, tools, and links to support those interventions. Second, today we'll hear from Harrison Community Health Center, and again, very excited to be able to really provide those real-world examples of diabetes, particularly in the time of the pandemic and COVID-19. And then our third speaker, or large content area today, is really in response to feedback we heard from all of you, particularly in our last session last week. And that was about wanting more information, not only about patient engagement, but remote patient monitoring. That came through loud and clear in the chat box, in the comments, in the feedback. And so today, we're going to have a member of our NACC team who's on you'll hear some more from Rita in a moment about her engagement with the Million Hearts Initiative. But as many of you know, and have heard the data from CDC and others, in this time of COVID, and as we look at those that are most impacted and affected by COVID, we see a high level of correspondence with other comorbidities and things like hypertension, in addition to diabetes and other clinical conditions. And so we thought this was a great opportunity to share some very important lessons, tools, and resources that are coming out of the Million Hearts Initiative. So again, three exciting content areas today. And then towards the latter part of our call, in addition to a Q&A portion, we are going to also gather some feedback from all of you on some things we're thinking about in terms of remote patient monitoring, on some actual patient toolkits. So we'll save that suspense and that excitement to a little bit later in the call, and look forward to your engagement, and again, potentially the opportunity these could be resources available to all of you in the field. And then we'll close the session with announcing or sharing some information. Some of you may have received an announcement in recent days about our challenge, and again, more to come on that, but there is an opportunity for you to share some of the concrete work you've been doing around systems change, certainly around diabetes, but also potentially in other areas as well in the COVID time. So with that, I'm going to shift the program back to Luke Ertl, who will jump into the diabetes change package. Thank you.
Thank you, Cheryl. And won't dive into it too much, but just a real brief overview again for anyone who hasn't been on the previous webinars. But as Cheryl was mentioning, a lot of this webinar series does focus on our diabetes change package, which includes a limited set of evidence-based interventions that health centers can readily and quickly implement, along with tools and resources for implementing them, as well as tips. Just a quick overview of on your screen in front of you, you can see a lot of the different interventions that are touched on, and the ones highlighted, we will be touching on those throughout the presentations today. So we'll be looking at some around the EHR and structured data, standing orders, self-management. So talking a little bit or delving into EHR structured data, and from the evidence or in the diabetes change package, it provides some of the evidence background or the behind why these interventions are important and helpful with improving diabetes care. So meaningful use of data from the EHR enhances quality improvement efforts and improves performance. And the action step along with it is creating a registry of patients with and at risk for diabetes using the EHR, with the goal of being able to create a dashboard that dives deeper into the population. Along with that, as I had mentioned earlier, the Diabetes Change Package does provide a number of different resources for helping you to implement this intervention. Next thing that we'll talk about is diabetes standing orders. So the widespread use of protocols and standing orders increases that efficiency by allowing staff to work independently. So taking some examples here that we've come across, that we've gotten from some different health centers, we put together some different templates for standing orders that you can use within your health center and implement pretty quickly, pretty easily as well. With that, I'm going to go ahead and turn things over to Erin Frazier from Harrisonburg Community Health Center. And Erin Frazier has been with HCHC in a variety of clinical roles over the past 6 years and currently serves HCHC as the Director of Clinical Operations, overseeing the risk and compliance, quality improvement, patient experience, and access management plans, as well as the provision of clinical services at Harrisonburg. Erin originally entered healthcare in the research and development sector after getting a Bachelor's of Science in Biotechnology from James Madison University, with a focus on antimicrobial proteins and vaccine development. Erin then received a Bachelor's of Science in Nursing from Eastern Mennonite University, has been following her passion for community health nursing and patient-centered approaches to healthcare delivery ever since. Erin lives in the beautiful Shenandoah Valley of Virginia with her husband and 2-year-old daughter. And with that, I'll go ahead and turn it over to Erin.
Great. Thank you so much, Luke, and thank you for the opportunity to share about some of the challenges and successes that we've had with diabetes care in general and also during COVID-19. So I really appreciate that. If you want to advance to the next slide. The first thing I wanted to highlight for everybody is the context that we're working in. So for those of you who are not familiar with Virginia or the Shenandoah Valley of Virginia, as an FQHC, we have 3 clinic locations and 1 administrative office. We have a location near a hospital in Harrisonburg. We have 1 that is temporarily closed right now that was located in a long-term care facility, and a 3rd in Elkton, Virginia, which is a very rural community at the base of the mountains where Shenandoah National Park is. We serve about 18,000 patients a year across all of our facilities. We do have primary care, prenatal care, Title X services, dental, integrated behavioral health, which includes psychiatry and counseling. We have a Ryan White care management program, and we have a pharmacy that's going to be opening in September of this year. One of the things that's extremely unique about our FQHC and often surprising when you look at Harrisonburg on a map are the diversity of our patients and our community. So the most common patient languages that we serve, English, Spanish, Arabic, Kurdish, Kinyarwanda, Kiswahili, Tigranian, Amharic, and Russian. We are a refugee resettlement community and have been for more than 25 years. So people are coming with a refugee visa to live in our community and work and establish families and communities. And so we have a large influx of non-English speakers every year. And we also, because of being a rural agricultural community, have a lot of jobs, and so people do a secondary migration from other places that they've been originally settled. So we have an extremely diverse patient population. On an average day, about half of our patients don't speak English, and we manage that by having a staff of interpreters, and we hire as many bilingual staff as we can. We also have some interesting subpopulations that come into play when we're talking about population health management. So we are an old order Mennonite community, and so there are multiple what we would call closed religious communities in our area, no electricity, horse and buggy, and a lot of them don't have insurance, so they utilize us as an FQHC. As I said, a refugee resettlement community. With agriculture, we have a lot of migrant and seasonal farm workers. We have a large poultry industry here. We also have some rural mountainous communities and small towns, and we do have 4 area universities and colleges. So we serve individuals from all of those sub-communities, and there are, of course, individuals with diabetes from all of those communities. So we have a lot of challenges just around our patient population. You can advance to the next slide. One of the questions we get the most often is how we're staffing. And so I think I thought it would be helpful to put forward our current model. So my role is listed at the top. And as you can see, there is then centralized oversight over our quality improvement strategies, our risk and compliance strategies, access strategies, and the patient experience. And all of those committees then influence the work and how services are delivered. So we have a clinic operations manager who oversees our lab coordinators and basically then all the clinical staff. And so we have multiple clinical operations coordinators stationed at each facility who directly supervise the nurses. They lead weekly huddle. They help manage the day-to-day clinic flow and staffing needs. And then we have a variety of support positions, communication nurses, a community resources coordinator, which is essentially like social work, medication navigator, which oversees our MAP, medication assistance program, our 340B program, and just does overall support with patients and providers on accessing their medications, either through their insurance or if they're uninsured. And then we have a clinical services coordinator that assists me with policy development and implementation. And currently she also is trained to provide diabetes education. So she's serving in that capacity as well. You can advance to the next slide. So just before we get into how COVID has changed our practices, I thought it would be helpful to kind of give you an idea of where we are in our focus on diabetes. So one of the things that we have done over the last year and a half is to move away from a care coordinator model. And that sounds a little crazy sometimes, but what we found is that when we had a diabetes specific care coordinator, anytime we had turnover in that role, we had significant lag time in the ability to in our ability to maintain that programming. So over the past year and a half, we've been working on bringing diabetes care coordination into all of the roles at Harrisonburg Community Health Center. A big part of that is nurse-driven population health efforts. So we do something called meaningful discharge, where our nurses are actually responsible for checking out and scheduling follow-up appointments for patients with chronic disease. Well, all of our patients, but especially those with chronic diseases, and we have a whole scheduling algorithm around that. It helps ensure that our patients understand why they're coming back, that they're getting in with their PCP and not just any provider, and that if there's any questions about their medications or how they're supposed to move forward with their treatment plan, that can all be addressed before they leave the building. We have an enhanced no-show communication and follow-up policy that our nursing team utilizes. So when a diabetic no-shows their appointment, we contact them in a variety of ways to ensure they understand the importance of their visit and get them back on the schedule. We also implemented something called a standard intake. We do this with a lot of patient populations. We have 25 providers that serve in our organization, and all the nursing staff are trained to cross-cover all of our disciplines. And the only way we can really accomplish that is by having standard intake. So we use our EHR templates to have standardized questions that all the nurses ask when they room a patient with diabetes. We also have implemented point of care hemoglobin A1Cs and have a standing order for the clinical staff to execute that so we can do real-time treatment plan updates. We also have a standing order for our diabetes foot exam, and that is completed by the nursing staff as well. We're in the process of working on a comprehensive standing order for all of the diabetic services, much like is listed in the change packet. So we're going to be working through that. We use campaigns to reach out to patients who are considered lost to care or overdue for their lab tests. So we're trying to use our EMR to its full capacity. We are in the process of applying for AADE accreditation so that we can bill for diabetes education and nutrition therapy services, with the goal of hiring a registered dietitian next year to do in-depth diabetes education. Right now, we're doing DSMES services 8 hours a week in partnership with our local hospital. We have a medication refill protocol to ensure that patients who miss their face-to-face visit with a provider are able to get enough of their medication so that they don't run out until they can get seen or rescheduled. That's a big cultural shift, and it can be a lot of work to get all of your providers on the same page about that, but that has been working really well for us. We do use EMR alerts to flag areas of structured data and remind our staff about gaps that need to be closed, and that helps with workflow consistency when you have this large of a team focusing on diabetes. We do weekly huddles with our providers, interpreters, clinical staff, and a behavioral health specialist, and they meet weekly to discuss populations of patients that are scheduled to come in for the next week and making sure we're closing those gaps. And then, of course, we are working on our diabetes care plans using an EMR tool and working towards billing CCM services. So that's a little bit about our current strategies. I did see one person popped up on the chat with a question about the interpreters. We currently use certified interpreters. So locally in our community, we have a company that provides certification testing. So the interpreters who come to work for us are certified to interpret in the language that they speak. For us, that's really important for patient safety to make sure that they are trained medical interpreters and not just someone who is bilingual. You can advance to the next slide. So one thing I wanted to point out, so we did get a technical site visit back in 2016 and really realized that, you know, the organization needs to get its head wrapped around diabetes. Around that time, we got an entirely new leadership structure. And so the reason I wanted to point this out is that for many of us who are working on diabetes, it's a long-term effort. And a lot of times when you start new strategies, your data actually gets worse before it gets better. So when you start bringing in those who are lost to care, when you start testing people at appropriate intervals and seeing those patients and engaging in those relationships, your data is actually going to get worse because you're catching people who are out of control. But consistency and persistence can actually lead to success. And so this was a slide that we shared with our staff at the beginning of 2020, just as a look back for key trainings that we did and the hard work that they've put into our new model and how successful that it's been. You can advance to the next slide. So with COVID-19, obviously there are enormous challenges related to continuing to care for diabetics or just any of our patients. I will say one area that has made it easier at HCHC is that we because of the populations we serve and aspects of our community, we see some tuberculosis. And so prior to COVID-19, we were already fit testing all of our clinical staff for N95s as well as our interpreters, and had a stash of N95s for that reason. So we were a little bit ahead of the game unexpectedly with PPE. And so that has made this transition a lot easier. I know that has not been the case for most FQHCs, especially in places that don't ever see TB. However, we've done a lot of the same things that everybody's done. We are offering telehealth and virtual visits. We use a platform called Blue Jeans. This was imperative for us because Blue Jeans allows three-way communication, so we could have an interpreter patch into the call or the video chat as well. Our EMR platform did not allow for that three-way call to take place. One thing that we've done that's a little different, we found early on that our patients who were sick wanted to come to the building and be seen by their care team. The patients who did not want to come in the building were patients who were well and needed to come in for their diabetes follow-ups. So we quickly purchased canopies and tents and had those outside, but instead of using them for drive-up COVID services, we've actually been using those to do our preventive services and wellness services. So patient education, lab work, point of care, A1Cs, vaccinations, all can take place outside of the building. So patients who are well they're less intimidated to come into the building where people have been sick. We run registries of all of our diabetic patients, and the clinical services coordinator worked with our medication navigator to make sure that all of our diabetic patients had all of their medications for a longer supply and set them up for delivery to minimize the amount of times that they would have to go out of their house, but also ensuring that they didn't run out of medication. We also use the registries to have our community resources coordinator and our diabetic educator follow up with patients about their access to food and medicine, make sure that they had a telehealth visit scheduled with their PCP, and then schedule their A1C in one of the tents so that we could make sure that we didn't lose track of those patients during this time, but also didn't unnecessarily expose them in the office setting. We have a partnership with the Blue Ridge Area Food Bank, our local food bank, who has set up delivery for patients that tested positive for COVID or who we've tested for COVID. And so we're able to work with them to make sure that our diabetic patients still get healthy and fresh food when they're sick, instead of having to go out to the grocery store or rely on family to come into the home. And one of the last things that we've done is we put out a call to our community for a fabric mask drive and COVID-19 sanitation kits, so that our vulnerable patients, in particular our diabetics, our patients with COPD and other chronic diseases, and families with young children, we could give fabric masks to the patients and their families. And that was really successful. I think we've had somewhere in the neighborhood of 5,000 or 6,000 masks donated over the past 12 weeks, and we've been able to give those away. You can advance to the next slide. One of the other things we did very quickly was pull together some diabetes-specific COVID-19 education materials. We provide this in 5 languages on our website. We have, of course, printed copies for patients who come to the office. We can send it by the portal. And so this is just a sample of some of the materials that we're able to come up with. That is the end of my slides and comments. I don't know if I should take questions now or just wait till the end.
We can go ahead and hold on questions. We'll do the Q&A a little bit later. We've gotten a ton of questions coming in, but yes, we will circle back to those a little bit later. Thank you, Erin.
Thank you.
So quick transition, as Cheryl had mentioned earlier, we will have a discussion about patient self-management and how that ties in with remote patient monitoring. So quickly taking it back to the diabetes change package, as we mentioned on our first webinar of this series, we talked a little bit about the evidence behind patient self-management and some action steps. And thinking about this whenever it comes to remote patient monitoring, there is evidence that suggests that telehealth is effective in controlling HbA1c, but of course, monitoring can only improve these outcomes if patients are using the equipment that they've been given as prescribed and know how to use it. So developing targeted interventions for the different groups of patients that you're working with around that activation and engagement levels is important to make sure that the equipment is getting used to its potential. With that, we've again included a few more resources from the diabetes change package, and on screen you can see the Quality Center's patient engagement action guide that will provide you with some more ideas on how to engage your patients more and being able to apply it to remote patient monitoring. So with that, I'm going to turn things over to Rita Lewis to talk about SMBP and Million Hearts.
Hi, everyone. Good afternoon. Again, my name is Rita Lewis, and when it comes to SMBP, it's a great resource that we have found to help patients who are managing their blood pressure with their providers in their home setting. So it's a great tool for patients who you may not want to come in for certain visits because of their risk, to be able to measure their blood pressure at home. And there are some tools that I'll reflect on a little bit later that have been really great in the care setting, where they also sync to the EMR so that it reduces error in doing a paper recording of the measurement. But it is a tool that can be used not only to help patients with hypertension, but also those patients with diabetes who also have uncontrolled blood pressure, as a way to help them manage that aspect of their diabetes. So wanted to make sure we kind of bring it all together, where I'll mostly be talking about SMBP as it relates to blood pressure measurement and patients with hypertension, but also that it relates to this particular population setting because of the importance of managing blood pressure for patients with diabetes. Next slide. Here on this slide are several resources that are provided by the CDC's Million Hearts program. I work specifically on a project through NACHC, where we are looking at various ways of managing blood pressure and hypertension. So we also have what is called the SMBP Forum, which are quarterly meetings to discuss areas that are important for home measurement. So if you're interested in learning more, the Million Hearts SMB page has a variety of resources and information and testimonials that are really helpful in terms of the benefits of SMBP for patients to help monitor and manage their blood pressure in conjunction with their clinician. What we have found anecdotally is that these patients are able to better identify certain triggers or certain issues to help with their discussions with their providers when it comes to managing their blood pressure. Additionally, we have listed here is the Target BP program, which is also providing tools and information for providers to learn more about blood pressure measurement and improvement and how to engage their patients. Next slide. One tool that recently was released is the Million Hearts Hypertension Control Change Package. It was updated to help with different tools and resources and protocols that clinicians can use to help manage patients' blood pressure. While it is specifically targeted at talking about hypertension specifically, because we're talking about managing blood pressure, there will be tools and actions in here that will be relevant to patients with diabetes who also have uncontrolled blood pressure, and ways that may be useful to help manage that or communicate with those patients, or the tools and resources to help them manage their blood pressure over time. This is a resource recently updated by the CDC, and it was released, I believe, 1 or 2 weeks ago. So I just want to make sure you're aware of just things that are available in the hypertension or SMB specific space that have some crossover to the diabetes population. Next slide. Additionally, I want to highlight some other resources and programs that we've covered across the Million Hearts projects and as well as the SMBP Forum. One of those is Heart Safe Motherhood. It's a program that is through the University of Pennsylvania, and they work specifically with postpartum women who have maybe had preeclampsia or have already have hypertension, and helping them monitor their blood pressure after giving birth. Also with women who have gestational diabetes or have type 2 diabetes would be a great resource to look at on how they use text messaging alerts and reminders to help remind their patients to monitor or measure their blood pressure at home. It's also a great way, given that we're dealing with new moms who may have trouble getting into an office visit, as a way for them to measure their blood pressure and be in communication with their provider, just to keep a better watch on managing their blood pressure and what's happening with their health as they're becoming a new parent, and also trying to maintain their health over time. When it comes to blood pressure devices at home, or SMBP devices, the American Medical Association recently updated and promoted this website called Validate BP. The great thing about this site is it talks about home blood pressure devices that have been validated in the United States for home use. Before, there were devices that have been validated through Canada and other countries, so this is a list that has been validated by sources and authorities in the United States. So it's a great way and tool to look at if you're recommending any devices for your patients, devices that may be available for them. Also recently, some NACHC staff were part of a recently published paper in looking at home measurement and different protocols that work, especially when collaborating with community partners. Some of the work was done in previous Million Hearts contract work that we had done, but it's a great paper to see how health centers were able to engage with community partners and resources to help get devices to patients, so they were able to measure in their homes, that were able to be beneficial in terms of them managing their blood pressure rates better in conjunction with their clinicians in their care. Lastly, you'll see here is a recently released joint statement from the American Heart Association, as well as the American Medical Association, and a policy statement on SMBP, and the benefits of the various protocols and resources that are out there to encourage use of SMBP for patients. So there's lots of information that is available on the web, as well as for not only just for patients' education, but also for clinicians and protocols in their education as well. Next slide. I also want to highlight a webinar that was recently done by NACHC to talk about managing hypertension virtually. While it does use the term hypertension, it still relates to using self-management, self-measured blood pressure monitoring as a way to help with patients who have hypertension or have uncontrolled blood pressure to work with their provider, especially during COVID-19 when getting inpatient visits is a little bit more of a challenge. But in this webinar, it does discuss ways that providers can work with those patients who have uncontrolled blood pressure from home and remotely through virtual visits that will be helpful. At the link you'll see here on the slides, you'll be able to access the recording as well as the materials and the slides. That will be a great way to highlight ways that you can use these strategies. You'll see here that 2 community health centers were part of the presentation, so it does bring a health center angle and perspective that will be very helpful, I think, for this audience. And I believe I have one more slide, and if not, okay, that's it. But I do want to highlight that when it comes to getting devices that are accessible, unfortunately, there are few resources for getting devices covered through Medicare or Medicaid, but what many health centers do is working with their local and state departments of health that look at grant programs that they're able to purchase and then rent out or loan out these devices to patients so that they're able to use them as their providers are working with them to manage their blood pressure. So while it is unfortunate we don't have easy ways to get access to the devices or patients pay for them out of pocket, there are ways that health centers have found that have been beneficial to get access to these devices so that they can provide them to their patients in these types of care settings. And that's it.
Great, thank you, Rita. Oops. Luke, maybe we'll jump ahead one more slide before circling back to the discussion question, because I think this slide is a nice segue into or connection to what Rita just shared. And so, as she commented, there's lots of evidence that speaks to the importance of self-measured blood pressure, and certainly other remote patient monitoring tools. And so, one of the things that NAC is exploring is the idea of in the coming project year, creating what we're calling patient toolkits. And so, with this new growth in virtual visits and patients receiving care in their homes, we're looking at, to the idea of putting together, as we said, this toolkit that would have, among other things, could have blood pressure cuffs, could have thermometers, could have scales, could have a variety of things that you as a health center could provide to patients. And again, through some of our projects, you'd be able to access some of these toolkits for your patients. So more to come in the coming weeks. If you're a part of this webinar, we'll be circulating information on that opportunity. But today, as part of the discussion here around remote patient monitoring, and then we'll flip back to the other slide, the discussion slide, which is what are the kinds of things that you would want to see in a patient self-monitoring toolkit? And so if you can use the chat feature and type in, if there, again, whether it's blood pressure cuffs or scales, thermometers, whether there's more resources specific to diabetic monitoring and blood glucose levels or things along those lines. So, look, we can flip back to that other slide for the discussion. And again, our question for you is, what would you need if you're not already doing remote patient monitoring? What are the kinds of things? So toolkit could be one of the responses you're typing in, but also other things around logistical support or training support. We see things like scales coming across. Daniel mentioned blood pressure cuffs, thermometers, glucometers. Anything? Does anyone want to raise their hand and share any experience they have with remote patient monitoring, or you can type it in the chat box. I do like the recommendation for a flashlight. That's a very good recommendation in a toolkit, very practical. So we'll just pause a moment and let, again, you to type some things in the box. Luke, I'll let you also jump in if there are particular comments you're seeing as they're scrolling in or questions you want to pose in addition. Rita, I'm going to ask you a particular question. I think I saw flash through here, but so great. Again, appreciate all the comments coming in. But Rita, in your experience through the Million Hearts Initiative, and I know through the NAC team, you have several different projects, as you mentioned, but is there any particular feedback you would call out from health centers that had experience placing loaners or giving equipment to patients in their home? Any particular advice around the blood pressure cuffs themselves or some logistics around that?
Sure. So with the particular health centers that did this, they were, many of them that I'm recalling, they were able to get grants to purchase, or they just found funds through the health center to purchase them themselves and then just loan them out. So that's where it became successful, because they found that with the costs and with the patients that they're working with, it is challenging for them to afford it. So they wanted to make it affordable. So they did loan them out on a temporary basis, the patients they're working with, and they found that to be successful. I do want to touch on kind of looping into this question that I saw in the comments about integrating it with the EHR. And while there have been some EHRs that have been successful in direct either Bluetooth or direct placement into the EHR, there still has been a challenge. So it's something that for some of the platforms is something they simply have to call their EHR vendor and have the feature turned on, or discuss that in their contract with their vendor. But it is a feature that that most health centers should be able to get access to, and then finding the right devices that, that are well suited or on the same wavelength as the network, the vendor, and uploading to the EHR. So I know it takes a little bit of work and planning, but they have found success through either purchasing them through health center dollars, getting grants, or other donations or funds that they've used.
Great, and maybe I'll ask a similar question for Erin, and then Luke, I'll turn it back to you for additional questions. But Erin, if you were to envision, and I love your scenario, it's probably one of the first I've heard of the tents used in a well way, and so we often hear the health center examples in COVID for the testing and et cetera, and certainly, you know, we hear of drive-by for HbA1cs, et cetera, but again, I think you're using it in such a robust way, which is very exciting. Would you envision that something along the lines of a toolkit, or maybe that's also, you may not call it that, but it looks, certainly you're giving access to some different tools, possibly food through your food bank partnership. But could you speak at all or just react of whether providing patients who are coming, for instance, through your tents, recognizing certainly lots of challenges around language and refugee status, et cetera. What would that experience, or could that experience look like in a health center like yours?
I think if we had the funds and we're in a space to purchase that type of equipment, it would be very successful. I'll say this isn't related to diabetes, but we do something similar for breastfeeding moms and for newborns that need a Billy Light. So we have purchased breast pumps and UV, well, they're called Billy Lights, but special blankets that allow newborns to get the light treatments they need at home instead of having to go into the hospital setting if they have jaundice. And so we have that type of equipment on loan pretty regularly from all of our facilities to just help facilitate care and keep people in our program and limiting the times that they have to go to the hospital. So I could see benefits to the remote monitoring even pre-COVID, but certainly with us utilizing telehealth more. I'll say telehealth has not been hugely successful for us. I'm not sure if it's because of the language barriers. I know we have some rural areas that don't have good internet, and not a lot of patients have devices that are compatible. So it hasn't been a huge success for us. We have never closed our doors to in-person care, and a lot of our patients kept coming to see us, which is also why we had to shift around how we were using the tents, because we weren't able to, we didn't want to turn away any patients. But I definitely could see this getting folded in with the other equipment that we already loan out, for sure.
Thank you. Luke, I see we have a couple of hands raised. Maybe I'll turn it over to you to call on those folks.
Sure thing. And Joan Draper has had her hand raised for a little while, so I'll go ahead and open up her line first. And then I see Joseph Humphrey from Lanai Community Health Center had mentioned in the chat that they have Bluetooth-enabled remote SMBG and SMBP since 2017. So I'll go ahead and open up his line after that to be able to share his experience. Joan?
Okay. Can you hear me?
Yep, loud and clear.
Oh, okay. Okay, I wasn't sure if I had to unmute myself. Actually, my question was back regarding interpreters again, and I just didn't know if they train people for diabetes education that are non-medical people, or do they use MAs and nurses and then the interpreters? We're trying to determine how to train people and who to train to give actual diabetic education for our highly Spanish-speaking population.
Sure. So all of our interpreters are certified, and the vast majority of our nursing staff are bilingual, either in Spanish or Arabic Kurdish, and we also have a Russian-speaking nurse. The clinic services coordinator who's doing the diabetes education currently is bilingual in English and Spanish. Although I will say that because we provide all of our services with an interpreter, it's pretty normal for the nurse or the provider to carry out their education session, and they're the ones who are trained, and then we just let the interpreter work their magic. So certified and trained interpreters don't need to have all of the training. I mean, it is helpful for them to be familiar with the curriculum and to have a good rapport and relationship with the staff, especially if they're going to be working with them regularly. But we don't focus our training efforts on the interpreters specifically.
So the interpreters are not necessarily MAs or clinical people. They're just clinically, they're just trained by medical interpretation. Medical
yes,
interpretation. Okay,
yes.
Thank you.
Mm-hmm.
That's it. Thank you.
Okay, Luke, so I think we'll turn it now over to Joseph.
Yep. Joseph, you're...
Am I on?
Yep, you're online now.
I'm online. Okay. Yes. Lanai Community Health Center has been very, very active in SMBP, and we've been using telehealth since 2014 through Zoom, primarily for specialty care. But we're one of the first centers in the country to go to remote monitoring and home blood pressure monitoring, or SMBP, starting in 2014. In 2017, we converted over to Bluetooth-enabled equipment for both blood pressure as well as blood glucose, and have a care management software that's integrated in with our electronic medical record. A couple recommendations. We've been able to, just briefly, for Medicaid, we've been able to get authorization to buy the blood pressure cuffs. It's very easy to argue that that's medically necessary given the amount of evidence we have. And so that's been covered. Patients that are private pay, we've been able to get discounts on the blood pressure cuffs at $35, and people that are working are very willing to pay $35 to be part of our program if we promote it correctly. So anyhow, that's a whole story in itself. Our Bluetooth-enabled system is really the backbone is our community health workers, because it takes a while to get people to be able to use the technology, particularly the older folks that have diabetes. But we have the same we have got the same process for the diabetes and the SMBG and SMBP, so patients that have both are able to send in their results remotely. And I guess sort of one of the bottom lines is that it's the software that really counts, not the blood pressure cuff. SMBP requires averaging the blood pressure over several days with multiple readings. And that gets very tedious if you have to put it into a spreadsheet or anything. But when you have computers, well, you should let computers do what they do best. And so, and collaborating with a similar software is much better than everybody going out and buying their own, which is really tough with community health centers because we all like to reinvent the wheel. So I'll talk to the NAC folk later, and we can give you more information on that. Anybody that wants to can get back in touch with me if you. I can put my email address into the chat box.
Perfect. Several other questions came in that we can go ahead and direct to Aaron. So Aaron, you had mentioned that there were your standing orders mentioned that they implement, or are they implemented in all visit types? Or are they just focused on diabetes visits?
That's a really good question. So I would say that the standing order allows that staff to execute that service anytime that it's deemed do. So what we encourage our staff to do for the patients who have a history of regularly attending their 3-month visit, doing that at a diabetes-specific visit is certainly most appropriate. But we do have a decent percentage of patients who don't maintain their regular 3-month visits and come see us for a same day or an acute visit. And we have trained our nurses to go ahead and just execute those standing orders, even if it's not a diabetes-specific visit. So we do both. And over time, the nurses kind of learn and get to know their patients, and we work really hard on empanelment and making sure that patients have a relationship with a nurse and a provider. And so they typically know their patients really well and kind of have an idea of if they can skip it at that same day sick appointment or if they need to go ahead and get it done. That also gets planned out at the weekly huddle. So all patients with diabetes are discussed at the weekly huddle. One way, it seems like a really small detail, but one way we facilitated that is when the nurse schedules the follow-up visit for diabetes, they write the value of the A1C in the reason for the visit. So because we use point of care A1C, if they're scheduling me back for a visit and my A1C today was 10.2, my follow-up visit in 3 months is going to say follow-up diabetes dash 10.2. So when they're looking at the schedule a week in advance, they can very quickly see who's under control, who's not, and kind of have a game plan for addressing those gaps.
Great, thank you, Erin. And another question that we've had coming in several times was who performs the diabetic foot exam that you had mentioned earlier?
The clinic staff nurse and the MA, whoever is working with the provider. So we do annual training on implementation of that exam, and we have a standing order for that service. And then we do leave the socks and shoes off so that when the provider comes in the room, they can still see their feet as well. But all the components of the foot exam are completed by the nurse or the MA at intake.
All right. Then with that, it looks like we are running low on time, so I want to go ahead and turn things back to Cheryl. Thank you very much, Erin, for all your answers on those questions. There are several more that we had come through, and unfortunately, we won't be able to get to them right now, but we'll try to go ahead and get some answers or do a little bit of a follow-up, Erin, for some of those bigger questions and then get them out to people. With
yeah,
that,
absolutely.
Thank you. Cheryl?
Great, and in fact, I'll invite Camila Silva to come up. If we could advance 2 slides to talk about NACHC Quality Center Challenge, and we'll do 2 things. One, we'll also bring up a couple evaluation questions because they're going to provide the NACHC team with critical information that guides us in terms of our next steps, a bit of what we talked about earlier, and also evaluate today's content or the impact and how helpful it was. So with that, Camila, I'm going to turn it over to you to share a bit about the Quality Center Challenge.
Hi, Cheryl, and hi, everyone. So as Cheryl mentioned, and you should have received this email, but if you didn't, we wanted to make sure you were aware. So NACHC Quality Center is launching a challenge for best promising practices. Our goal with this is really to gather the best promising practices from the field, and this can be practices, policies, tools, basically things that your organization has created, adapted, and implemented because of the changing situation with COVID-19. You will have until the end of this month to make your submissions. After that, we plan on acknowledging and rewarding the best practices with IHI's Join Work scholarships. And then finally, we'll be able to create a national toolkit to disseminate those best practices. So one thing I will be doing right away is sending the link on the chat, so that way if you can go ahead, it will take 2 to 3 minutes to make a submission. It's very quick and easy, and we hope that you're able to participate. Cheryl, back to you.
Great. Thank you, Camilla. And again, she'll go ahead and put that link in the chat box. And if you have your concrete tool, policy, practice, anything you want to share, please submit it now while you have those few minutes. And again, you'll be considered for that or have an opportunity to receive that scholarship. So thank you. Luke, while folks are hopefully submitting some things and wrapping up the evaluation, I'll let you say any closing words. Thank you.
Thank you, Cheryl. And again, appreciate all of our speakers today and throughout the series. But thank you, Aaron, for your presentation, Rita for joining us as well, for all the information that you've shared today. With that, we'll go ahead and give it just the last couple of minutes to be able to enter in your responses to the polls and provide us with some feedback on this webinar series, to help us guide what work and what types of things we need to do for the future, webinars and presentations. Again, thank you all for joining the series, and take care and be safe. Thank you all.